the slides are visible.
Yes, you are audible and visible. Also,
perfect. So TPN workshop is actually like a half day or a full day workshop, but I'll try to be as concise and practical as possible. So we'll just skip through the importance of nutrition, indications of parental nutrition in the NICU, calculation and practical preparation of TPN, monitoring and adverse effects, a little bit about the laminar flow, and setting up TPN practical points in your unit. So when you talk about early nutrition, the physiology is very easy to understand, that the baby was receiving a constant nutritional supply from the placenta, and as soon as the cord is clamped, there is an abrupt stoppage. Newborn baby, premature especially, have very limited stores, and the compensatory mechanisms are very limited. So the protein starts breaking down immediately, which is something that we don't want. And there is a much higher requirement of nutrients per kilogram of body weight for the premature babies. And when you talk about evidence of early aggressive nutrition, there are definite short-term outcomes that have improved, outcomes till discharge. And there is promising evidence that early aggressive nutrition improves neurodevelopment, although most of this is indirect evidence. So when I started getting into neonatal nutrition, the main thought was, what is the goal of nutrition? What happens if some baby gains weight a little slow, some baby gains weight a little fast? Finally, if they all do well, does it really matter? So the main goal of nutrition is always long term, that they should have good neurodevelopment and they should be healthy individuals. However, the problem with that is that there are so many confounders in the NICU stay. There will be infections, there will be comorbidities. So does nutrition directly impact long term outcomes will be something that will always be never 100% confirmed. The second goal of nutrition is to make the babies grow. So I want adequate weight gain, I want adequate head growth. That could be my second goal. But again, what if the baby is ill? What if the baby is edematous? Is the weight gain reliable? So again, some problems come. So when I was doing my fellowship in neonatal nutrition in Vancouver, they said that you just focus on intake. Focus on intake, focus on illnesses, and forget about the other two outcomes, because they are going to only show up later. So when you talk about intake, also there are some restrictions in fluid. What if the baby is not tolerating? Then how will you give it? And what about availability? Certain nutrients or certain enteral proteins, parental solutions may not be available in your setup. So there are some problems with the intake. For growth, like I said, there could be a concurrent illness. The requirement could vary. There could be a variable growth trajectory. You don't know, the growth trajectory, the genetic potential. And long term is always a confusion, because every NICU variable can have an impact on the long term outcome. So again, when I start my NICU work every day, my primary goal of nutrition is to provide adequate intake, because I have very little control on the growth, and I have even lesser control on the long term neurodevelopment. So the energy needs of preterms, this is quite standard. There is a basic energy requirement for the metabolism, some more energy for activity, thermoregulation, growth. If the baby is on enteral feeds, then there are two more things: specific dynamic action for breaking down the food products, and the fecal losses. So on an average, the energy needs for a preterm baby is 110 to 130 if the baby is on enteral feed, and around 85 to 100 if there is parental nutrition. So when do we start PN? When should you start PN? If the baby is less than 30 weeks and less than 1.2 kilos, then we should definitely start at birth. If it is between 30 to 32 weeks or 1.2 to 1.5, we should still start it if the baby is not anticipated to be on significant feeds by day 3. Any older neonate whom you feel will be, not be able to feed till 5 days, including surgical abdomen and surgical conditions. And periodic nutritional assessment for every baby in your NICU, on day 3, day 5, day 7, if you feel that the baby is still NBM for some or the other reason, there should be an ongoing assessment. Then when do we start? Should we start on day 1 or should we wait for a few days? So if the criteria is being met, preterm baby meeting criteria start right after. Like I said, the protein or the muscle breakdown starts very quickly. There is a huge protein catabolism. So start protein and dextrose fluid immediately after birth. Lipids you can also start on the day of birth. And other cases you can start like a partial PN and some sort of peripheral fluid solution. What about term infants? So if there is a surgical abdomen, you know that you're not going to feed the baby, start immediately after birth. But for other term babies where you're not sure, or if it's a sick baby, you can start on day 3 or 5. So is there any hesitation in starting, parental nutrition for full-term babies on day 1? So there was this paper, in NEJM for critically ill pediatric patients. that actually showed that withholding parental nutrition was superior. So not starting parental nutrition for critically sick preterm babies was actually better than starting PN on the first day. So this is that paper which was published in NEJM in 2019, early versus late PN critically in children. And like the primary outcome was actually showing that starting parental nutrition on day one actually did not help improve outcomes. And then they had a post-hoc analysis of newborns also, which said that critically ill children and neonates have lower target for calories and proteins, and you can delay the initiation for 3 to 7 days. Now, this is just to sort of, highlight that parental nutrition is not without any side effects. You can't just keep giving parental nutrition left, right, and center, and there are certain monitoring that needs to be done with it. So what are your components of parental nutrition? Your main component is your fluid and electrolyte. The next is your energy, proteins, carbohydrates, lipids, macronutrients, and vitamins and minerals. So coming to your fluids and electrolytes, there is this transition phase, which means that all children have, the initial weight loss. So your birth till the maximum weight loss, 0 to 7 days, is called your transition phase. Then there is an intermediate phase where, from the maximum weight loss to regaining birth weight, that is usually a 7 to 14 days, and a stable phase where, beyond 14 days, once the weight gain starts. Electrolytes, as you know, must be added during the transition phase. The starting fluid rate is usually between 50 to 100, depending on the unit. If there is incubator use, you probably can start at a lower, total fluid requirement. If the baby is more premature, you might need slightly higher fluid requirements. The daily increment, most protocols say you can increase by 20 ml per kilo per day, but it should be consciously done after checking the weight, urine output, ideally serum osmolarity, but sodium is an indirect marker of serum osmolarity. So you can do it based on the serum sodiums for premature babies. The sodium requirement daily is 2 to 5 milliequivalents per kg per day. Same for chloride, and for potassium it is 1 to 3 milliequivalents per kg per day. So that would be your typical fluid and electrolyte plan on day one. Coming to ELBW babies, some special characters is, one is that, first or the best thing is to minimize losses. As minimizing your losses is much better than replacing them, because you can never replace the ideal fluid that you are losing. Aggressive parental nutrition, again, what happens is that you can often see that there is low potassium, low phosphorus, and high calcium, something like a refeeding picture where, the baby, you have not started parental nutrition on day 1, 2, and suddenly you start aggressive parental nutrition, then you can have that. So you should keep an eye for the complications. And in most centers, there is a base fluid for the parental nutrition, which is either chloride based or acetate based. So depending on the tendency of the baby, if you think the baby is having slight metabolic acidosis, then you can have your sodium acetate as your base. If the baby is, slightly alkalotic, you can have chloride based, or you can have a 50-50 solution. So in centers where there is a central pharmacy preparing a parental nutrition, they also request you to decide what sort of base you want for your fluid, whether you want an acetate or a chloride based parental nutrition. So after fluid and electrolytes, next is the energy component. So for the first day, because there is a restriction in your total fluid intake, the calorie requirement is also slightly low. So 45 to 55 kilocalories per kg is your calorie requirement. For premature infants on TPN, the total calorie requirement is 90 to 110. But the main factor that is unknown is that if the child is sick or is critically ill, how much extra calories you provide. Sometimes providing too much is also not good. Calorie distribution, again, 50 to 55 kilocalories should be provided by carbohydrates, 30 to 35 by lipids, and a small component, 10 to 15, by proteins. But your endogenous proteins should never be broken down for calories. So that part is very important. So for that, there should be a fixed protein to calorie ratio. That is, for every 100 calories that you provide, there should be at least 3 to 3.5 gram proteins, or the other way around. For 3 to 3.5 grams proteins, you should at least provide 100 kilocalories, so that your body's endogenous proteins are never broken down for calories. Again, for proteins, there are a lot of studies, lot of evidence that starting early proteins is very important. So start at 1.5 gram per kilo per day right at birth to prevent a negative nitrogen balance. Early amino acid infusion will also improve your glucose control, so less episodes of hyperglycemia. There is a little controversy whether can you start directly at 3 grams or do gradual increment. So most units still have a protocol for doing gradual increment, where they start with 1.5, increase by 0.5 every day, This also fits in with the daily increase in TFI. So, if you increase your TFI, total fluid intake, from 80, 100, 120, so your protein increases. And your maximum parental nutrition dose for protein is 2.5 to 3.5 gram per kilo per day, which you should achieve by day 2 and 3. So this, as you can see, is slightly lower than your enteral protein requirement. So your enteral protein requirement as per SPGAN is 4 to 4.5 grams per kilo per day. So how do you check for tolerance of protein? So, most protocols say that you check your blood urea nitrogen, but there is no exact cutoff that after what point we should get worried or at what point you should stop. Normally we say that if the, blood urea nitrogen is rising above 40, 45, then you just provide, your basic protein to prevent breakdown. So which would be anywhere between 1 to 1.5 gram per kilo. If you have renal injury, again, if your creatinine is high, you should restrict your proteins to your baseline requirement and not provide too high proteins. Similarly, if you have severe metabolic acidosis. So rather than your tolerance or side effects of proteins, these measures like BUN and acidosis simply tells you that your proteins are not being utilized ideally. So it suggests protein oxidation rather than utilization. And there is no study or no evidence to say that very high BUN means that it is actually causing damage. It just means that your protein is being wasted and not utilized. So it is better that we don't give that. The next component is carbohydrates, which is our main source of energy. The requirement initially to start with is same as the endogenous glucose requirement, which is 4 to 6 mg per kg per minute. And you can, because it's a source of energy, we should increase it by 2 every day to reach a maximum of 12 to 14 mg per kilo per minute. But it should also be guided by blood glucose level. So if you are having hyperglycemia, then probably increasing your GIR to very high levels is not recommended. Should you use insulin just to get high GIR so that you can provide calories? That used to be a thought, but however, it has not shown to improve any outcomes, but it just increases your lactic acidosis. So again, increasing your GIR, if despite your sugars being high, is not the best practice. So rather than that, you would decrease GIR rather than providing insulin with high GIR. Coming to the third main component, or the macronutrient, which is lipids. So lipids is a very essential component of energy. It also prevents your essential fatty acid deficiency. It's very common if the baby is not given lipids by 1 week only, you can see those typical fish scale like skin lesions. It's very important for your brain and retina development. Again, the starting dose on the day of birth is usually 1 to 1.5 gram per kilo, and you can increase it to a maximum of 3 to 3.5 grams per kilo per day. There are two preparations available. Nowadays, most units are using the 20% intralipid, which is preferred, as there is a lower phospholipid content in the 20% content, and also obviously lesser volumes if your baby is very tiny. It does need light protection because there can be hydroperoxide formation, so you do need to protect it from light. Again, what do you monitor when the baby is on lipids? There are adverse effects like hypertriglyceridemia, and for very long use, there is the cholestasis. But again, there is no specific cutoff beyond which you would say that, oh, this triglyceride level is very, very worrisome, and let me stop lipids right away. It is just again supposed to be like a byproduct. So you need to be watchful. You need to reduce your lipid dose, but every unit has a slightly different cutoff. There have been certain warnings or worries that we have had when we use lipids. What if the baby is having, very, very high bilirubin? Does it displace the bilirubin? What if the baby is having PPHN? Does lipid cause sepsis? So again, there are, weak associations, but no really strong causation. So that's why I've just written caution. These are not contraindications to lipid, but they are areas where, you just need to be cautious, maybe not push lipids to the highest dose, or, slow down on them. The composition of any lipid solution includes a neutral triglyceride, a phospholipid for emulsification, and a glycerol for tonicity. So these three components are there. And currently the popular lipids are, one was the intralipid 20%, and the newer one is SMOF, which is soya, MCT, olive oil, and fish oil combination. There is also a fish oil based lipid which is available, which is omega-1. This is sort of not FDA approved. This is supposed to be used as a if the baby develops cholestasis related to parental nutrition and still requires parental nutrition, you can go with omega-1. So it is available in the Western countries as a special request solution, provided if the baby is having definitive cholestasis related to TPN. The other components, the important micronutrients, so the minerals are calcium, phosphate, and magnesium. The requirements are usually pretty standard. They are available in all guidelines. Calcium prevents early neonatal hypocalcemia. phosphate is sort of a neglected, mineral, which is extremely important. The deficiency can occur quite early. It results in muscle weakness, respiratory failure, cardiac dysfunction. It's so, in India, Potphos, which is the brand for IV phosphate, was not available for quite a long time. It's been recently made available. So the practicing neonatologist would know that whenever you start TPN with only calcium, within third, fourth day, you find your calcium levels to shoot up. It goes to 1.3 ionized calcium, 1.4, 1.5, and then you end up stopping calcium. So the problem is not with your calcium. The problem is that there's no phosphate provided simultaneously. So the bones can't use it. So, despite giving calcium, you are still having severe osteopenia because the calcium phosphate is not really being absorbed in the bone. And the moment you give phosphate, the ionized calcium drops from 1.3 to 0.9 because now the calcium is being utilized. So there is an ideal calcium phosphate ratio that has to be maintained in the parental nutrition. Obviously, we need to watch for crystallization, because if it exceeds a certain limit, then it can actually cause precipitation. It can block your central line. Magnesium is another essential mineral that needs to be supplied. It is usually quite safe to be given. And except if the mother has received recently high dose of antenatal magnesium, you might need to monitor the baby's magnesium levels. How do you know if it's adequate? Ideal way would be to, check your urine calcium phosphate. And if it is slightly higher than the expected, then you know that, it's being excreted. So there is enough in the body. But practically, we don't usually practice that. So we just provide it in the ideal molar ratio, and we assume that the baby is getting it. Vitamins, it has to be added daily to the parental nutrition. Addition to lipid solution usually increases the stability of the vitamins. Its doses is preterm infants is not established. And the combination for newborn, again in India, the availability is not there. So we use the pediatric MBI. We sort of have prepared a standard parental nutrition where we know that this much volume will be added to this much volume of the TPN. So we know how much will be going to the baby. But there is no specific solution of multivitamin that is, established for premature babies currently here. These are the, daily requirements of multivitamins in premature infants. Again, this is from Espegan, so it's very easily available. Then coming to the next question, how do you make your parental nutrition protocol? Should it be standardized or should you individualize it? So standardized parental solution essentially means that you decide that, okay, this, I'm going to have this much ml, say 35 ml of 10% amino N, and I'm going to add 100 ml of D10. So that will be my 150 ml standard stock TPN solution. And if I give it at 60 ml per kilo per day or 80 ml per kilo per day, my baby is going to receive X amount of protein, X amount of glucose, X amount of calories. So that is sort of, called a standard parental nutrition. So what is the advantage of that? As you know, the advantage of that is that it is less error prone. It is standard. Anybody can prepare it. It is not prone. It is not going to be different if some new nurse makes it. She knows that itna hi add karna hai, itna hi ye karna hai. And but the problem is that does it meet the nutritional requirement of all? So how can you make a standard solution for different babies? The other option is to make an individualized parental nutrition. So how do you make an individualized parental nutrition? That is labor intensive. You have to actually calculate, the protein for this each baby based on the weight. You have to also calculate the calorie requirement for the every baby, and it will be specific. Like for baby A, it will say that at 25 ml amino N, this much ml D10, this much ml multivitamins. So it is actually ideal because actually you will be meeting the requirement for each baby, but also there are very, very high chances of errors. And with errors also infection, because if the staff is not confident in making it, then they are more likely to sort of make errors with it. So what can you do? How can you modify? So when I was in Vancouver, they had 4 standard solutions based on the weight, because one shoe, does not fit all. So there was a starter solution, which was just a protein, dextrose, and mineral solution. So on day 1, any baby who would come would get a starter solution. So, the TFI obviously would be depending on the weight, but otherwise it would have a starter solution. And then there were 3 solutions for less than 1 kilo, more 1 to 1.5 kilo, and more than 1.5 kilo. So there was, TPN solution A, B, and C. And they had slightly higher proteins for less than 1 kilo because they have more protein requirements and so forth. They had minor modifications so that it was done. So it was actually a standard PN, but as 4 standard solutions. Here at Surya, we have 2 standard solutions, but we also practice standardized parental nutrition. Individualized parental nutrition, say you have a lot of resources. If you have a TPN pharmacy, Or if you have a TPN, preparing nurse whose job is only to prepare TPN, then you can practice individualized TPN. There are a lot of softwares and calculators available where just enter that I want to give 2.5 gram protein, I want to give this much calories from glucose, I want to give this much calories from fat, this much calcium phosphate, and it will give you how much ml to add. It will ask you how much ml solution you want to prepare, and you say that I want to prepare it in 500 ml, or I want to prepare it in 150, 200 ml, and it will give you the exact volumes. You simply print it out and give it to your TPN pharmacist, and they will do the needful. So that is called a individualized parental nutrition preparation. There are these 3-4 apps. Actually, there are many apps. These three are well made apps, so well popular apps. The NNF has created an app which is NNFI issue, so that has a TPN calculator. Neonate AI is by one of my colleagues, Dr. Venkat. So artificial intelligence Neonate. This also has a very good TPN calculator. And Umesh Vaidya sir in Pune has created this Kimaya TPN neonatal application. So the principle is all similar. You just enter the baby's details, enter how much grams of each micronutrient you want to give, and it will give you a final solution that this much volumes need to be added. So they are quite popular. They are user friendly, and they all have a printout option. So once you enter it, you can print it out and send that sheet to your pharmacy, and they will do the needful. They will add everything in needful. The individual preparation without an app is quite difficult. What all things you need to consider is that for the individual, you need to subtract the fluid from the umbilical artery, whatever heparin, dextrose fluid or heparin saline fluid is running. Antibiotic volumes, etc., need to be subtracted. Dextrose percentage and GIR needs to be calculated. Amino and dose, needs to be converted to volume. Each additive, electrolytes, minerals sort of need to be connected. Adding heparin if it's a central line, and lipids separately as a volume infused over 24 hours. And you can prepare the total volume into a convenient size, so 100, 150, 500, depending on what syringe or what infusion device you want to use. So individual calculations need to be done, but they are tedious without a software or a calculator. So I'll run through this short video of how to prepare TPN. So the step one is to calculate the doses. So this is a standardized TPN prescription in our unit. We add 35 ml plus 110, so that gives us a 150 ml. These are the three apps. So I'll just take you through the Neonatal AI app. So you go to calculator, select TPN calculator, type the baby's name, age, and then gestation, day of life, and then you write the total fluid that you expect. And now you write about each of the baby's requirements. So, and then once you click submit, it gives you the full volume, how much volume to add in the total of each of the specific component. And this can be printed out, and it can be just handed over to the nurse who's in the injection room. So she will prepare it exactly in that concentration. So the most important step practically is, to do a sterile preparation. So you need to follow strict hand hygiene. You need to do gowning before entering the TPN room. So we wear a sterile gown. We have a separate injection preparation room and a TPN room. So the step 3 is to use a laminar flow. So laminar flow, the door of the laminar flow should be closed. So it should be a separate room. The surface of the bottles that you keep, so this is a laminar flow. While preparing, also need to know that it has to be, taken to the bedside. So we cover the injection tray with this sterile sheet. The injection trays are autoclave, but we do still cover them in a sterile sheet for transfer. And for preparation, you need to keep all the injections in the laminar flow, turn on the UV light and blowers at least for 30 minutes prior to the procedure. So she's making the TPN fluid in the 150 ml infusion. So she's added the dextrose, adding the electrolytes. The vial has to be punctured from the side. So from the side. So this is a vertical laminar flow. So that's why she's puncturing from the side so that her hand doesn't block the laminar flow airflow. So the amino vein or the proteins, whatever, one by one, they'll add all the constituents. Before puncturing the side hub, we have to clean the surface with an alcohol swab for ensuring sterility. This is the amino vein that will be added to the TPN solution. So the calculations have to be done before entering the TPN room, and that sheet should be ready so you know exactly how much to add. Adding minerals and micronutrients, so calcium, phosphorus, and other things will be added. And if it's a central line, you also need to add heparin. 0.5 units per ml is the usual dose of heparin. So depending on your total volume, you will decide how much mLs to add. Then connecting again, we should be a completely sterile technique. So 15 seconds scrub the hub. So the hub of the central line is being scrubbed with an alcohol swab. And the TPN solution that is being, so this is being connected to a PICC line that the infant has over the saphenous vein. So those were the steps of, preparing and connecting a TPN. So then comes the next question that, okay, you have prepared the TPN, connected it, how do you monitor? So what all things need to be monitored? The most important thing that I always tell my students is that the dose that you have written and what actual intake is the baby getting, are they the same? Because many times what happens, due to some or the other reason, the total fluid intake is reduced. So you have calculated a 3-gram protein intake, depending on a fluid rate of 5 ml per hour. But you come and find that the night team has reduced the fluid intake back to 4 ml per hour because they found the baby edematous. So every nutrient intake will decrease. So, and this is what commonly criticized point in multiple studies that have been published on nutrition, is that the dose that they have recommended or prescribed and the actual intake that the baby gets, they are usually never the same. Next monitoring is the biochemical parameters, a little bit that we discussed on tolerance and safety. And the final thing to discuss is the baby growing because of my TPN, right? So biochemical monitoring, again, what is the role and evidence? There is absolutely no or minimal evidence regarding biochemical monitoring, but still every unit practices it worldwide. So you need to monitor your electrolytes, blood glucose regularly. You need to monitor your minerals like magnesium, calcium, phosphate, alkaline phosphatase for your bone osteopenia. Babies who receive proteins, monitoring blood urea nitrogen, the pH for acidosis and albumin levels. Lot of protocols say, but we in our unit don't measure albumin. Some units even measure pre-albumin, which is considered to have a shorter half-life. You need to measure your liver functions and renal functions periodically. And for lipids, you monitor the triglycerides. So there is no cutoff, like I said, but this is something that you need to monitor. And if your triglyceride is rising or your bun is rising, you might need to decrease the dose of the parental nutrition macronutrient. Next is growth monitoring. So the problems with growth monitoring is that you don't know if the birth centile should be tracked or the parental centile should be tracked. What is the genetic potential of the baby? Often in the first week they lose quite a lot of weight. So should you take the lowest centile or their birth centile? Again, is something that is not clear. A lot of studies have focused on minimizing the initial weight loss. So how do you optimize TPN early and you prevent that initial weight loss, or time to regain birth weight should be faster. That is one of the short-term goals. But how fast to regain birth weight, again, nobody knows. Probably by day 7, day 10 is usually considered standard. Should you use growth charts or should you use Z-score? Again, Z-score is much more objective. I'll try to show you by this example. So can you see the line C, which is on top? Is that a continuation of A or B? I've covered this central part. It looks quite confusing. Initially, when I looked at it, I felt that, oh, this seems pretty straightforward. But when I actually, make this transparent, it is actually a continuation of A. I'm sure a lot of people would have said B, that B and C are continuous. So, these are all visual illusions. So the growth charts actually are not supposed to be very ideal because they, tend to pick up growth failure very, very late. And if you actually plot on the Z-score, you find that, oh my God, this, baby was trailing on the Z-score much before you could actually see it visually on a growth chart. So most literature, recent studies show, focus on the Z-score. So this illusion is called Ponzi illusion, where you can see that it is an illusion of curves where it's very difficult to know which line is actually going to continue, because it's a ongoing continuous curve. So it usually picks up growth failures quite late. So next is complications. So what complications can happen when you give TPN? Majority of the complications may be related to the catheter. They are called CLAPSI or CRIPSI, so central line related bloodstream infections. Occlusions of central line can happen, which can be thrombotic occlusions, non-thrombotic occlusions. Some of them can be due to crystallization compatibility issues of your TPN solution. Extravasations can happen, especially because our TPN usually has a very, very high osmolarity. They might be acidic. If you check the aminoven bottle, you will know that the osmolarity is quite high, close to 850, 900 milliosmoles. The pH is quite acidic. The pH is around 4, 4.5. So, very, very high chances of extravasations. The vascular access can be an issue with TPN. Non-catheter related complications, PN associated liver dysfunction is the most common, cholestatic complication. It is usually attributed to prolonged use of lipids. If the baby is NBM, it is exacerbated. If the baby has severe sepsis, it is exacerbated. Usual measures include, you need to decrease your lipid intake. That is usually the first step. So if I see that the baby is developing cholestasis, I'm giving 3 grams per kilo. I usually make it 1.5. Other option is to use a SMOF solution. So since we have started using SMOF, lot of our babies on prolonged parenteral nutrition don't develop cholestasis. And like I said, the omega ven or the fish oil based parenteral nutrition solution is probably considered the most superior for this complication. For, in countries where they give parenteral nutrition for short bowel for 3 months, 6 months and all, it is very, very common. Here in India, I have not seen it as much, because most of our babies don't require parenteral nutrition for very, very long. But when we have babies with chylothorax and other issues where we can't feed for 2-3 months, we definitely see this. Metabolic bone disease again is a problem, because optimal intake is an issue. There is a worry that calcium phosphate, if you give, will precipitate. IV phosphate availability is still an issue in many centers. So metabolic bone disease again is very common. And poor growth, again, this is a situation with enteral parenteral nutrition, because you can never match intrauterine growth. So EUGR again is extremely common. Access, do you need central line or peripheral? It can be given with a peripheral line. It needs to be monitored. It will depend on your final osmolarity and the pH of the solution. For central line, you can use umbilical, PICC line or IJV. It's better to have 2 lumens, because a lot of times the injections, antibiotics may not be compatible. So Y-side compatibility needs to be checked. And intermittent injections before giving through the central line, you always need to check whether they are compatible with the parenteral nutrition solution. So just a couple of slides about laminar flow. So basically it very simply has a filter pad to filter out the dust. It has a fan and it has a HEPA filter, which is a high efficiency particulate air filter. The fan will suck the air through the filter pad. The filter pad will trap the dust. And this pre-filtered air is passing through the HEPA filter, where actually the decontamination happens. And this sterile air constantly flows in the working area. So there are 2 types of laminar flow. One is the horizontal flow and one is the vertical flow. Both have their advantages and disadvantages. The HEPA filter basically is the thin pleated sheet of boron silicate microfibers. It can retain very, very small particles as small as 0.3 micron. So it actually traps most of the bacteria and viruses. There is an additional sterilization factor which is called a UV light. So it has a germicidal radiation which prevents and breaks down microorganisms. So because the UV light is toxic for us, we usually put it on 30 to 45 minutes before entering. And once during the preparation of the parenteral nutrition, we close it. So you clean your laminar flow surface. You keep all the injections there, the dextrose fluid, aminoven, everything in that surface. Put the UV light on, put the fan, everything on, the HEPA filter, everything on, and put it on for 30 minutes. Then when you go for preparation, you just turn on the UV light. The fan, filter, everything still stays on when you prepare your injections. So just practically, when you want to set up TPN in your unit, what do you need? You need availability of solutions. Again, this is very easily available now in India. Your dextrose, aminoven, intralipid, SMOF, electrolyte, minerals, and vitamins. You need a special preparation room with laminar flow hood. Most importantly, you need trained staff for preparation and dispensing so that there are no accidents. You need a good IV access, and you also need a facility for monitoring the central line. side effects of TPN, and a microbiology department to check if there is any infections related to your TPN. So practical consideration, to summarize the whole presentation, step 1 is to always calculate your TPN dose. Decide beforehand, do you want to give standardized or individualized TPN? Sterile precautions are absolutely important because you don't want babies to have infections. Laminar flow should be set up. It should be well arranged. So that should be there. Then actual preparation, mixing, dispensing should be done by somebody who's a little trained, who knows, the importance of heparin, the problems with crystallization. After swirling, mixing, he should check the TPN solution. Are there crystals, particles in it? And somebody to connect it in a sterile manner. So I would like to thank all the attendees for staying back so late